Yeah, welcome back, Santa Clarita, to KHTS Radio with the Providence Holy Cross Health Hour. We're joined today with Mark Domante, the clinical analyst, actually THEE clinical analyst with Providence Holy Cross, and pretty much one of the only ones here in all of Southern California. So we're really lucky to be able to have him. We just got finished chatting about data mining during our first segment, and meaning, taking a look at all the different information that's made available to us to our electronic medical record and trying to actually see trends and try to make changes to our practices and making more better practices, taking a look at our processes. This segment, though, Mark, you're involved with something really special, and Dr. Raji is actually, I think he's the regional leader on this, right?
Yep.
So why don't you introduce it?
Yeah, so it's called patient blood management, and so what it is kind of an interdisciplinary approach to looking into patients who are getting transfusions. So there are several clinical studies out there showing that giving a patient someone else's blood has a lot of harmful risks attached to that. That includes increased length of stay. They're more possible to get an infection. And they could have some adverse events. For example, they may be getting some reactions and whatnot. So a lot of different harmful events that could happen for giving a patient someone else's blood. And so patient blood management really gathers everyone in the entire team, and again, an interdisciplinary approach to kind of find out, how are we utilizing our blood transfusions, blood products in general. Orthopedics, your department's a huge one involved. So it really is looking into how we can reduce giving blood products and how we can better serve our patients in terms of quality as well.
Right, and now we had the opportunity to obviously talk when coming up and before the show and such, but a lot of this now is sitting on meeting criteria. Mm-hmm. And that criteria it's more of a national related criteria that's actually being made available to us and supported through the Providence Health System. Can you talk a little bit about the criteria? Maybe we don't need to talk about the numbers per se, but just the different things that we might look at.
Yeah. So one thing I did forget to add is that blood transfusions is one of the most overused procedures in the healthcare industry. So that's why we want to get into this. But in terms of the criteria, it's a hemoglobin of 7 and a hemoglobin of 8 for cardiac patients and critically ill patients. So we definitely want to kind of assess the patient prior to them just pumping up a patient with blood. We want to see are there other alternatives that we can give to kind of anything that we can do prior to resorting to a blood transfusion or giving patient blood. So
now and then correct me if I'm wrong too, is that oftentimes we're also hearing that there's blood shortages, that our blood banks start to get a little bit low, especially during times where there's known traumas. When the weather starts to change, we have a lot of car accidents, and so we will go through our blood banks pretty quickly with that. And so anything that we can do to lessen the need for transfusions, not only is it going to be better for our patients, obviously there's risk factors that are involved with that, but it's also going to allow us to maintain a blood bank to try to be able to be helpful to when traumas actually occur, and maybe not have any delay in getting people blood when it's absolutely necessary.
Yeah, exactly. And for us, we don't have a blood bank or donor center in our hospital. Correct. So we rely on the community, to give to American Red Cross or some other organization that kind of handles that or facilitates that. So, as you mentioned, if there's a shortage within the community, then, we have no other option as well. So
correct. Now and we being where I'm working at the hospital as well, we've been kind of keeping an eye on this as too, and that interestingly enough, even though they may hit a number at a certain level, they may not go right to maybe blood transfusion. They might just go in for an iron supplement, and they have other tests they can take a look at to determine, is it truly just a low blood volume or a low blood number, or is it something maybe that we can supplement within their blood that will allow them to well, for lack of a better word right now, is to kind of perk back up to bring their numbers to a point where it'll make that patient much more comfortable.
Yeah, exactly. That's where the whole, reassessment comes into play. How can we, are we looking into this patient? Are we looking into the alternatives? As like total iron, I think was one.
Right.
And there's another technique that they use to give the patient, it draws the patient's blood out and pumps the patient back with their own blood. So, saving, a pack of red blood cells, for example. So there are other alternatives, other techniques that we can use to kind of save, if there's any shortage or, save blood just in general.
Right. I do know on the orthopedic side, we are using auto transfusers.
Yes.
On some of our total joint replacement patients, especially if there's a known that they're going to have maybe a little bit of a hematoma after surgery, that they can actually pull that blood off, and that blood can then be, for again, lack of a better word, maybe scrubbed and immediately put back into the patient. So the net loss is quite minimal, and the net gain can be significant.
Yeah, exactly. They're being pumped with their own blood, so it's kind of like it's the same, and it's cleaned out, as you mentioned earlier. So
now just to kind of give it an impression, because it's actually a really big deal right now within Providence specifically, and I know that a lot of the other hospital systems are also looking at this and how we can do better. But in the very short period of time that we've been really kind of addressing this and taking a look at that, it's astronomical, and I want to kind of impress upon everybody is that I'm going to give you a percentage of improvement in utilization that we're requiring less transfusions by a certain number, but I think it's really important to understand is that in a hospital in general nowadays, since everything can be done as an outpatient, it's more sick individuals now coming into the hospital that are requiring longer stays. And so what we found is that even though our lengths of stay for our more sick patients are increasing, the level of care required for those patients, because they are coming in sicker, is greater. Our blood utilization is down almost 15%.
Correct.
That's unbelievable.
Yep.
And which congratulations to you, Dr. Raji, and the entire team. And let me tell you that the team is busy. They're meeting pretty much what seems like monthly.
Yeah. They're meeting monthly.
And the amount of data that is being pulled, because I received something from one of your counterparts just the other day to review through, and it was pretty explicit as far as who's using, why, is it reasonable, is it not reasonable, have other things been addressed? Unbelievable.
Correct.
And that's because of you.
The entire team, But eventually we've gone from, like you mentioned, from the compliance rate, it was about 50, now we're up to like 75% compliance rate with the triggers of 7 and 8, and the decrease in about 15% from total volume. So now we've actually evolved into a regional effort, the California regional. So every ministry within Providence is kind of learning from each other. How can they learn from Holy Cross? How can we learn from St. Joe's or Tarzana? So we're kind of sharing this ideas, and this actually evolved maybe a month or two ago. So this is how we, we're trying to share best practices, and this is how we evolve as a ministry and as an organization as a whole.
And it is practicing medicine. It's every day, every week, every month, we're fine-tuning things here and there and finding that we can be even more effective in certain things. When I'm watching what our docs are doing and what our caregivers are, the care they're delivering, I'm thinking, how in the world could we even possibly top that? But they're doing it, which is unbelievable. So now it may not seem like that 15% may not seem like much, but if we admit 3,000 patients a year, just throw a number out there, let's say, you're looking at 450 patients who didn't have to require blood. If you can spread that amongst all 5 of our ministries, all of a sudden that's 450, let's say the same numbers. We're looking at, if my LA Unified math is correct, that's 3 million. No, it's not. It's, we're looking at thousands of units of blood that we're saving.
Correct.
That can go to people who are trauma patients, or to our, perhaps we've had some of our oncologists on, some of our cancer patients whose blood numbers are going down, that we can make sure that blood is always available for them.
Exactly. And, from a hospital perspective, coming from the administration side, We are getting less and less reimbursements from, Medicare, CMS. So the hospitals are actually getting paid less. We're being asked to do more without receiving any funding. So from the administration side, each pack costs around $250, roughly. But if you take into account the physician time to put in the order, the nursing time to administer the unit, laboratory time to kind of cross check the blood, transportation, it costs about $1,100 to $1,500 per unit of blood. So times that by how many units we've saved. I mean, from a business perspective, the hospital perspective, to kind of have that cost saving opportunity so that we can invest our money in, patient care or some other, clinical or quality, program to, further increase, quality for the patient.
Absolutely. And we forget, healthcare, though it is an important thing, there is a business aspect to that. And just to be able to keep the doors open, we need to do well and be better.
Yeah, and if we can save that money, give it to some other program, orthopedics program. For
yes, absolutely.
And if we can give you guys some money, give the money to the the frontline staff. How can we make their lives easier so that we can make the patients' lives easier? Kind of like transferring that the dollar figure to
kind of pay it forward. Almost.
Yeah, exactly.
Which is kind of a nice concept, and with that idea, we've been able to invest in all of our caregivers by bringing in education. And was about a month or two ago, we had our hospital offers to our physicians continuing medical education, where we bring the experts in on a variety of different topics, and blood management was actually one of the topics, and I would have to say, probably one of the better attended as well.
Yeah.
Some of the pieces that were being discussed, I don't think we're too far off from actually putting that into action with us here at the hospital.
Yeah, exactly. We actually had 2 CMEs, continuing medical education for the physicians. One was on blood list management, and one was on patient blood management. But yeah, we, get physicians from across the nation. I believe, I believe one was from USC and one was from UCLA. The 2 that we had, but yeah, then we have from the cost savings opportunity, we can provide more of this education for the clinicians, getting these speakers or getting some other opportunities where we can kind of educate our team internally as well. Just having other opportunities to increase our education and increase our own staff, as you say.
Right. Now and then one of the other pieces that by doing the necessary due diligence to see how we can do better and what is coming up in the future. You had mentioned that we started doing not too long ago, I would say, what they call TXA injections, preoperatively and intraoperatively. And basically that decreases the amount of bleeding that occurs during surgery, if I'm understanding correctly.
Yeah, exactly. I don't really know too much of the clinical side. I'm not a nurse or anything. But from what Dr. Raji and what Karen Klein, who is my clinical lead, and me, I'm just the administrative lead. So, I kind of try to help them build the business proposal for these programs or these equipment that they need to kind of save, blood. And TXA is one of them. I don't really know too much of the clinical portion of it, but
Right.
I just kind of assist them in, trying to develop the plan.
And it has made a big difference. And I can remember back in the late 80s and early 90s, back when I was doing inpatient work, the number of patients who required blood transfusions after a total joint replacement, let's just say, probably was every other patient.
Really?
In fact, a lot of the patients were encouraged to donate 2 months prior to their surgery, to load up the blood bank, and then because they were most likely going to need a transfusion when they were in the hospital. And ever since then, the number of changes, minimally invasive, everything now is either done through an arthroscope or through a laparoscope at the hospital, that just by simply the innovations to have minimally invasive procedures have really decreased the amount of bleeding that will occur during surgery, because we're just causing less trauma. But the tranexamic acid, the TXA, has been fantastic. know, I mean, you know the numbers better than I do, but I want to say we might have only had maybe 20 or 22 transfusions to our total joints in 650 patients, where maybe 20 years ago it would have been 325.
Correct.
So, you know, that's a 99% decrease or so, which is just huge. What should we be expecting coming on in the future, though? I mean, what do we find coming up as far as the blood management? Is there anything that we're...
one thing we're trying to educate to our clinicians and kind of carry on to the regional team as well is try to have orders, blood orders less than 2. So we learned this from John Hopkins and the Joint Commission, which is one of the highest accrediting bodies in the healthcare industry. They had a slogan called "Why give 2 when 1 will do."
Right.
And so, you know, we want to educate that to our physicians, saying, you know, maybe if it's clinically necessary to give a unit of blood or units of blood, you know, give 1 unit first, you know, assess the patient, you know, then. Again, are there any alternatives? You know, what else can we do? And then if the patient really needs that blood, then we pump it again. We'll give it again. But you know, that whole slogan, "Why give 2 when 1 will do," is kind of like our next step. In addition to sharing best practice across the region, our numbers are pretty good. I would say we're probably one of the top in the California region. So we definitely want to share it to other ministries, and we could also learn from them. You know, what are they doing? That's increased their compliance rate or decreased their blood products transfused just in general. So that started about 2 months ago. So we're really in the process of learning right now. Last month we just gathered the team. So, you know, next steps will be, you know, what did you guys do at your hospital? You know, this is what we did at our hospital, and kind of learn from each other. So that's in the next I would say the next month or 2. We are applying for a Joint Commission certification for patient blood management. It's actually a completely brand new certification, so no one else brand new. No one else in the entire nation is certified yet.
Right.
It just came out the end of last year-ish. So we should be expecting a surveyor by the end of the year. So,
that's fantastic.
Yeah, for a blood management program.
It's tremendous, and you know that's one of the things about Providence is that one, they want to be able to deliver a good product. They're going to put together programs that are going to be you know, best practice oriented. Right. However, we want it to be reviewed. We want them to we want somebody to come in and take a non-biased, as you said, 50-foot level looking down at our program and really give it the once over to see what all is going on and what are we doing and how are our processes, because that's extremely important. We want to be successful. Providence desires and demands that success, and one of the things that we're finding more so is in mostly because the total joint accreditation, they also have one for that as well that we would like to be able to do, probably maybe apply for that in the next year or 2, is that a lot of it is how are you making your changes? How are you pulling your data? Right. You know, what are the metrics that you're looking at? Is it the same thing with the blood transfusion?
Yeah, exactly. You know, we could be thinking that we're doing something right, you know, this, and they have a brand new, fresh set of eyes come in and look at your program. You know, they'll, you know, give us opportunities saying, you know, you could really expand on this, or you guys are doing this great. And then, you know, we share that information with our sister hospitals in the entire system. So, I mean, having that kind of like a fresh set of eyes, or having that external knowledge, and Joint Commission, they go to hospitals across the entire nation. So, right. I mean, they see programs from everywhere. So, I mean, I'm sure they've seen from A to Z everything that's gone on. So, right. We're looking forward to, you know, having them kind of evaluate our program, see how we can improve or make improvements for the future.
And then also have that nod saying, hey, listen, you guys are doing this great. You're doing that wonderfully. Mm-hmm. I would probably say in that case then, one of the harder things, and this was also something we were experiencing when we were talking about when we were driving up, is being able to put our ego aside for a little while, mm-hmm. and actually just look at the data, look at the trends, and see that though we may think this is what's happening, this is what it's actually showing, and be willing enough to be able, and thankfully at our hospital and a lot of the Providence facilities, our caregivers are willing to actually look.
Exactly.
And if you know anything about medical providers, we have pretty strong egos, and if you give us that opportunity to be able to improve upon things and have it with good, justifiable, provable, best practice type data, are you finding that same experience?
Yeah, and that's exactly where the data comes into play. You know, we can prove our story. You know, are our improvements, are the process changes making the improvements in the data? So.
Right. So it's no longer the National Enquirer. Now it's more like the New York Times.
Correct.
Exactly. Exactly. Well, hey, we're coming up, just finishing up our second segment. Going to be doing a quick little wrap up in a few minutes. We're going to have some commercials coming up. You're with Mark Domante and Tom Burton from Providence Holy Cross during the Providence Holy Cross Health Hour with KHTS Radio, and we'll be right back. Now, welcome back, Santa Clarita. You're with us here on KHTS Radio with Providence Holy Cross Health Hour. I'm Tom Burton, the Orthopedic Program Manager, joined today by with Mark Domante, the THEE clinical analyst with Holy Cross and pretty much for the Southern California region. And it's been different today. You know, we've normally been looking purely at maybe medical conditions or surgical approaches. However, we kind of went a little bit behind the scenes really on it's kind of that back office, backroom type stuff with the data that we would normally spend time collecting and how we can utilize that data and trends. And, the last segment, boy, we were able to show exactly what your effort and the team's effort was able to do, decreasing blood utilization by 15% for a trauma center like we are. That's unbelievable, right? Anyway, so it's something different. You know, it interests me, and I'm really glad that you were able to join us with this. Is there anything as far as coming up in the future that you see as far as in your role, as far as the back office type stuff? You know, what do you see happening with data and such? We have a few minutes.
Yeah, I really think from a data piece, you know, bringing that business perspective. I'm not a clinical background. You have a PT background. Everyone else on my team is a nurse. So coming in with that business perspective from the data as well, bringing that into play, I think, you know, moving forward, especially with the electronic medical record being implemented in, you know, hospitals across the nation. I mean, data will be the next thing that, you know, hospitals need to will be getting into to kind of look for that, future predictability model, like the airline industry, for example. You know, how many errors do they have in how many flights, you know, compared to the healthcare industry? You know, we
hopefully
definitely
zero.
Yes, yeah, exactly.
Especially the ones I'm on.
Yeah. So hopefully we want to get to that error rate like the airline industry or the banking industry, moving forward. And especially the data piece will be that, you know, stepping stone for us to get us to that next level.
Yeah, and I had spoken with a few people before, and they said that the idea of being able to harvest data is probably one of the biggest missed opportunities occurring not only in the health field, but pretty much in all organizations in all different fields. It is so robust if you know where to go, how to get it, and some of it's just really just getting it.
Yeah, exactly. Even for me, sometimes I have trouble. I mean, it takes a while to extract the right data, you know, and then you have to validate it, do some QA. Is it accurate? So even, you know, digging through the data, you definitely need to do a lot of scrubbing.
Truly.
So everything doesn't come out clean in an ideal world. So.
And when you do have that aha moment where you look at it and go, but hey, this information is saying if this occurs, then this occurs, that aha moment, then the next piece is the why. And that's where that clinical background group within your group can actually step in and say, this is the reason why. And then that's how, you know, positive change occurs.
Exactly. You know, finding a partnership between, you know, the data and the clinical piece as well.
Right. And it's when you take a look at physicians in general, a lot of what the work that's being done by our physicians, by all of our caregivers, a lot of it is assessment of numbers in order to make a determination of what it is that they're going to need to do. So thank you very much for joining us.
Thank you so much,
We're
Tom,
just going to
for
kind of
having
give a quick wrap. I wanted to make sure that everyone knows that if you did need to reach out for any of the services that might be available at Providence Holy Cross Medical Center, you can easily reach us through 888-432-5464. And if remembering the number is difficult, just dial 888 Healing, Healing. We're located in Mission Hills. We're about 10 minutes away, barring traffic, and we look forward to hopefully being a part of your lives and delivering that care. You're with Tom Burton, Providence Holy Cross Orthopedic Manager, and you're joining us here on KHTS. Coming up next, you're going to hear from my doc in Dukov, and enjoy that, and I look forward to seeing you next month.